All right. I have been trying to work on my slides and they are not doing great things for me today, but it's okay. I don't actually need slides. I have this memorized. Hold on, let me try one more thing. If you guys wouldn't could just bear with me 1 second. Hmm.
If you want to email them to me, Dr. Weaver, I could run them for you.
Oh, okay. Um, that's actually a good idea.
Sometimes come up with those.
Well, good morning, everybody. Lindsay Weaver. I have the pleasure of serving as your state health commissioner. If I haven't had the chance to meet you before, I am on computer. Um, we FSSA and the Department of Health are co-leading the RHTP initiative. And if you're not fully aware, the Rural Health Transformation Program is part of the One Big Beautiful Bill Act. It's $50 billion that were appropriated to go out to states to specifically improve health outcomes, address technology, opportunities, access in our rural communities. Every state was asked to apply for $1 billion for the next 5 years, but the funding will go out year after year. So you get an appropriation each year, and actually you could get more or less in each subsequent year based on how well you're doing. Are you actually getting funding out the door? Are you meeting the requirements? Are you showing outcomes? Those are all the things that each state will be judged against. And we are competing with each other. So, for example, if Indiana does really well, fully expect for us to, then we could get more funding. If another state does poorly and they don't give them as much, then we can get more funding that way too. So this year, from our application, they actually awarded us 207 million, so 7 million more than we had originally planned and advocated for, so which is really exciting. But we had to go back and write how we would use those additional funds. And so we didn't actually get our funding fully appropriated or fully released to us until the end of March. Some very unique things that I do want to point out with this funding is that we have to have all of this, the $207 million this year, encumbered by September 30th. So March to September is a really quick time. If any of you guys have been engaged with the regional, hold on, I think I'm going to be able to do it. With the regional grow programs, you're probably thinking this is moving really fast, and it is because it is. Our hope is though that in the next through 5 years that we can like slow down a little bit, be a little bit more intentional. So don't worry if you're like kind of worry about where things are headed right now. We're going to continue to reevaluate what our opportunities are with each passing year. Okay, sorry. I'm way closer than I was before. I'm going to. Right. Can you see the screen? My slides?
Yes.
Yay! Good. Okay, now if we can. Hmm. So if I don't mess anything up, maybe I won't show you in the full form. Is that okay? Unless somebody wants to tell me how to do it on here. Slideshow. Wait, from start. Still good? You can
Yes.
see the slides? Amazing. Thank you guys. Okay. So this is all the things I talked about. Indiana has a very aggressive application. But I will tell you, as we talk to other states, I'm really proud of what we put forward. We believe that our locals have the answer. They know what they need across the state, and they know who the partners are in those communities that can help fill those gaps. And so we put a lot of funding to go out the door directly into communities. Just to give example, people are always wondering what's going on in other states. Like, for example, Kentucky has four statewide program. So they basically kind of said, like, we know what we need. We're going to do mobile health for prenatal care across the state, which is great. That is definitely a need there. We do expect to see mobile integrated health for prenatal care, but we want that to come from the locals. Who are the partners there that are doing that, or is there another way that they want to deliver that prenatal care? There are 12 initiatives. I think all of these apply to you all in your work. The first initiative is Growing Care Coordination or a Medical Operations Coordination Center. This is recognition that we have had decreased access to EMS services, emergency medical services in our rural communities. There are less ambulances. There are less people, workforce has decreased there, despite the number of runs continues to go up on a regular basis. This does twofold. One, it helps coordinate ambulances and the movement of ambulances, both for 911 calls, but also movement of patients from one hospital to another. Especially in the mental health space, we see patients waiting in emergency departments for 1 day, 2 days, 3 days a week, trying to help identify a place to go. And often EMS availability is part of that because sometimes they're transporting people, 3 hours across the state and then 3 hours back. So taking an ambulance out of service for 6 hours is a very difficult thing to do. So it's going to help coordinate all of that. The other thing that the Medical Operations Center will do is it actually will make sure patients are going to the right place. So if 911 is called for a patient, they identify this is a mental health crisis. The plan is to divert that patient directly to a mental health facility, a crisis stabilization center, rather than taking them to the ER, where, in the ER, I think if you don't know, I'm a practicing ER physician. We're pretty limited in what we're able to do. We can stabilize the acute, if it's a psychotic episode or whatever, but then beyond that, there is a delay in people actually getting the treatment that they need. So the Medical Operations Center will help police and EMS assess and then divert to appropriate location. This is also a preparedness mechanism. So if we had the unfortunate, situation where we had a mass casualty event, this helps coordinate the movement of ambulances and distribution of patients to the appropriate hospitals. Initiative two is growing community connections through Indiana 211. I am so excited about this. Our plan with this is that it's going to be 360. Just pushing patients or people to their resources, but actually, did they show up? Were you able to connect them? Maybe that community-based organization the person was referred to identified another need and were able to put them back in for a separate referral. It will also integrate 211 social service referrals into electronic medical records. So right at a clinician's fingertips, if they identify a social need, that they will be able to put in that referral, which is really exciting because we know a lot of our healthcare costs and things that are making people sick are have nothing to do with any medicine that we can provide, but it's making sure they have housing and utilities and food, transportation, etc. Um, Lots of different ways this will look. Either that, like I said, integration to the EMR. There will be a, website front facing, and just making sure, and also having navigators respond. So if it's, this person needs food, but I don't know who exactly I'm sending that referral to. You can still put in that there's a need there, and then reaching out to a navigator to help connect the patient to the best entity in their community. Initiative three, improving patient outcomes to enhance interoperability in tech. Also very excited about this. I'm a super data nerd. We should be making data informed decisions for all the people that we serve right now. And frankly, we can't because there's a lack of access to information. Most of our hospitals are connected to the Health Information Exchange. We do have a statewide Health Information Exchange, so we're really lucky. Many states do not have that. Some have none. Some have multiple, and they're not all connected. We do have one statewide. Most hospitals are. Very few outpatient providers are connected. None of our nursing homes are connected. And there's also an opportunity to connect our behavioral health services in there as well. Of course, making sure that we have all the appropriate, security and protections in place, but to allow that ability that if a patient is moving between different facilities, which they all do, that the providers that are there caring for them will be able to access that very important information. Where we're at on this right now is we are actually working to connect our long-term care facilities, their health data into the health information exchange is that first step, and then they're going to start moving out into the community to behavioral health practices and other outpatient providers for that connection. Initiative 4, pediatric and OB readiness. This is making sure that all of our emergency departments in our rural areas are prepared to take care of that critical OB patient or that critical pediatric patient. They don't see them very often, and unfortunately, many of our rural hospitals are struggling financially, and so they have to make a hard decision, like, hey, we haven't used this equipment in 2 years because thankfully, you rarely get these critical patients, and so many of them don't have that appropriate equipment. Training isn't readily available, so this is going to work closely with all of our hospitals. And data supports that if you have a pediatric ready emergency department, if all of our hospitals were pediatric ready, we could potentially save 50 lives every year. Initiative 5, cardiometabolic standards of care in rural Indiana. This is recognition that, again, our health is more than just your diabetes and hypertension medicine. It is also addressing someone's mental health. There's a mental health component to chronic disease. What about their physical activity abilities? So it's really that more comprehensive care. We have one cardiometabolic center of excellence in the state. We want to grow that to 8. So all of our rural communities have access to that type of training and wraparound services for their patients. Also funding to train clinicians across the state in lifestyle medicine. So 700 certifications, 500 trainings. We'll be pushing across the state the 5210 initiative. So encouraging people to eat 5 or more fruits or vegetables a day, 2 hours or less of non-work screen time, 1 hour physical activity, and zero sugary beverages. I'm also working on wearable tech to track health outcomes, and then a feasibility study to see how we can make it easier for people to leverage the double up if they are a SNAP beneficiary. Access to hospital post-discharge meds. We know that we see a lot of readmissions to EDs or visits to EDs and readmissions to hospitals because patients, we just kick them out of the hospital and say, here's your prescription. And so you can imagine, right? They are tired, they are sick, they have transportation problems. If they're in a rural community, there may not be a pharmacy that has good hours locally. And so they don't start that critical medication to treat their urinary tract infection or their heart failure or their mental health needs, and then no surprise, they show back up. So this will make sure that when patients leave the hospital after their discharge, they actually leave with their medications on hand. And it has been proven to decrease hospitalizations and ED visits very significantly. So very excited about that. We've had 50 hospitals in our rural communities that have committed to work on a plan to develop a post-discharge medication plan, or you may hear us refer to as meds to beds. 7 and 8, expanding teleconsult and telehealth access. This is really, how and where we need to transform and revolutionize how we deliver care. Frankly, we will not be able to have enough people out in our rural communities, but that doesn't mean people can't access the important work of or the important interactions with specialists, mental health providers, counselors. Behavioral support is one of the telehealth things that we heard about, or someone to support them through their nutrition questions and needs, all the different things. Also teleconsult, so that if you are a pediatrician in a community, very similar that we have with our B-Champ, and you need support taking care of a patient from a specialist, that you're able to connect directly, so doc to doc, or advanced practice provider to doc, whatever that may look like, to say, okay, it'll be 6 months plus 2 hours of transportation to get to Fort Wayne or Indy or Evansville to see this specialist. Let's go ahead and talk about this patient and what can we start doing for them now? Maybe even avoid having that transportation and that visit. So very excited about this. This is also looking at like tele ICU or telemonitoring. It really just expands the workforce. I just was actually talking to a clinician who worked in Alaska, and they've been doing this for quite some time. So I'm excited to see this be available in rural Indiana. Initiative number nine, growing our rural paraprofessional workforce. So again, knowing that we need to grow and retain healthcare, behavioral health, and also oral health paraprofessionals. It's not just docs and nurses who make the world go round. So investing in that healthcare paraprofessional workforce through recruitment and retention, doing rural healthcare academies for high school students, strengthening the community health worker ecosystem. How do we expand that access to reduce cost of care, and strengthen coordination. Initiative 10, clinical training and readiness, recognizing that we don't train enough medical students per capita in Indiana, and we are 50 residency spots short for how many medical students we train. So immediately, I always say when we graduate those medical school classes from IU and Marion, 50 of them have to leave the state to get their residency training. And we need those people to stay. And actually, Indiana has the best outcomes that if a student does their medical school and then residency here, over 70% of them end up staying in Indiana. And that beats like all other states. So we know that if we can keep them here for med school and residency, that they are likely to stay and practice. So we need to expand our residency. We're also going to provide physician incentives up to $300,000 for to incentivize physicians to go work in and live in rural communities. So up to $300,000 for a 5-year commitment. Also, great data on this that 10 years out, if they have that 5-year commitment and that stipend, 80% of them continue to work and live in those communities. So those will be available. The specialties that can receive those incentives are family med, internal med, pediatrics, general surgery, anesthesiology, OBGYN, and psychiatry. We're also going to be paying preceptors. So we know that in order to train all these new folks, social workers, nurses, NPs, physicians, that they have to have people to learn from. And we also know that if we expose them to rural medicine, they are more likely, 5 to 6 times more likely to practice in those communities rather than having no exposure to rural care. So we will be paying preceptors in our rural communities to take on learners, and they can receive up to $10,000 per year. Other states have done this. It looks like what it is done, the way it's done in other states is it's a tax incentive. Tax incentives for preceptors has already come up in legislation. So this is our opportunity to pilot to say, hey, does it work? Can we get more preceptors, especially in our rural communities, to engage in this space? And then what are the outcomes of that? And then also recognizing that we have a lack of OB providers, a decreasing number of OB providers in our state. We also don't have a certified nurse midwife program. So we'll be doing a certified nurse midwife program and expanding OB fellowship for family medicine. And then again, growing our behavioral health workforce, I talked about before, it's kind of combined with that other one, that community health or that other paraprofessional community health workers, et cetera. But they're also establishing a grant for behavioral health threat assessment and management training workshops, a grant for peer certification training and ongoing education. And again, that partnership with the healthcare academies. And this is the big one. And I hope you guys have all been engaged in this. If you care for people in rural communities, but are growing rural opportunities for well-being regional grants. This is 60% of our funding that will be going out across the state into the 8 regions. We told them that they have to address pre and postnatal care as we continue to see OB deserts in our communities, chronic disease prevention and management. And then our community told us their biggest needs were access to care, specifically transportation and healthy food. So every region has to address those 3 things. In addition to that, we ask that they address whatever they have identified as needs in their community. So we said, all of these hospitals do needs assessments. We provided them tons of data, all the regions, tons of data on, workforce shortage areas, what are their health outcomes, suicide, overdose, infant mortality, diabetes, et cetera, and said, look at your data, identify what your needs are. Right now, there's 8 coalitions. They're meeting weekly. There's subgroups who are also meeting on a regular basis. We do have committees formed for each of these regions. These committees are not the final decider of the funding. The state is the final decider of the funding, but they are there to help provide accountability, making sure that there is no particular issue. Like for example, like all the funding shouldn't just be going to prenatal care, unless everybody in that whole community comes together and says that is our biggest and only need. But or hey, we forgot about these three counties in our region, or you forgot about this partner. So their accountability and kind of, like to help for oversight, but not the final determination. And every region will write one application for that entire community. Here are the eight regions. The dark colored counties are considered fully rural. So everybody in that community is eligible to receive funding to take care of people in those communities. The stripes are considered partly rural. Either they just have a couple census tracts that are rural, or maybe they have a critical access hospital. Only those census tracts or that critical access facility are eligible for the funding. The white areas are not considered rural at all, but really important. If you are in Monroe County and you are a organization that cares for people in Lawrence, Martin, and Greene and Brown, you are eligible to receive the funding, but that funding can only go to support to the people who live in those rural communities, if that makes sense. So I fully expect for entities who are in the white areas, or if that's where their seat is, to receive funding, but they just will have to show how the funding is only helping support the rural communities. An important thing to remember is that our population, only 27% of Indiana's population lives in these, but like a lot of land area. But I do think that all this work and these initiatives will help elevate the entire state. We're going to continue to evaluate this. Like, I fully recognize that there are parts of, like Howard, that's rural, and Delaware, that is rural. And so we'll continue to evaluate needs as we move on for the next 5 years. Just on that other slide too, that we have the Hospital Association, the Rural Health Association, and the Primary Health Care Association are all helping to support those coalitions. Where are we at in the process? Right now, they are starting to actually they've done their needs assessment, they've identified their priorities, and they're starting to think about, okay, what initiatives should we put forward in our application for future funding? And that is a lot. And let me see if I can stop my share here. Stop share. Am I good?
Yeah, you're good.
Okay.
Perfect. Yeah. So we do have a few minutes for questions, and I received one from someone who had to hop off that I have. But before I jump into that, any questions that people have for Dr. Weaver? I know that was a lot of info.
Was any of this new, or is everyone like, we've heard this before and this is no longer helpful for us?
I think what I'm hearing from members, Dr. Weaver, is that mental health has been mentioned in the top three areas in each of the regions, and
Hmm.
yet there doesn't seem to be a lot of funding support for the mental health. And so the disconnect with that and how to navigate that disconnect. Also, like you and I talked about, not creating additional silos or services like for crisis and mobile, for example, but being able to use the current network. We, as a network, have built crisis services. Every member has a level of crisis, whether it be mobile or crisis receiving centers. So, how do we work together to ensure those services are sustained versus creating another silo? So, those have been kind of the main questions and concerns. Do you have any insight on those two things that could be helpful to members? Like, how do we advocate that behavioral health is supported in these regions?
Yeah, I mean, I think again, I really am looking to these communities to say, here's where our priorities are now. Here's where what we need to do quickly. It really does matter, like what is shovel ready right now, right? So that funding can be encumbered by 9/30, and then any kind of like newer programs or development, et cetera, that may take more time would be like a year, two, three, four, five initiative and program. So I think even though maybe now there's not funding, I don't think that's not potentially in the future, right? That funding can go for the regions and these communities. I do think it's important that you advocate if there's already services. So I do not want to see that there's a duplication or a new where they feel like they have to make this mobile crisis unit where one already exists. So I really want you guys to say this already exists, and actually we'd be able to extend further with X amount of funding then. We do there is a we have to remember that I really want to see that people not just advocate for their single issue. Just like I don't want to see a hospital worry about themselves, people who are mental health in the mental health field, just mental health or just OB. Like we really need to look across the board and say, where are there opportunities to collaborate so that we can raise, the healthcare access in our entire community? Because even though you say that, I've heard from some communities say there's too much of an emphasis on mental health in our region, and I'm worried that there's too much focus there. But I
Huh.
think we're going to get there because
Right.
I trust Hoosiers. I know everyone's going to work together. They're not going to just worry about their central focus. They're going to acknowledge where, each of these could potentially, need to be, okay, this is now, this is later. These are the potential, initiatives that we can do to address that. And so I think, yes, advocate for what exists, where opportunities are for extension, that this should, what are the gaps? How could this be leveraged? But I think, again, just really important to make sure that, there's a level of collaboration there and that this is not a competition. The ones that we're going to fund the most are the ones that come forward and say, we have a behavioral health unit and a hospital and a FQHC. They're all working together to address mental health in our OB patients, and making sure that we're getting them wraparound healthcare services, right? Like that's what we want to see out of the applications.
Perfect. And then the question I received is, will there be an opportunity to seek funds for EHR upgrades or replacement? Much of our interoperability is limited by an aging EHR no longer supported. And also, a lot of our CMHCs currently are paying for iHigh, but are limited by aging infrastructure. So, is that something that could be considered with these dollars?
So for EHR upgrades, that funding should be out of the region. So that's where you would have to advocate that for that EHR upgrade. I have to do remind you too that it can you could there, for replacement it can't you have to be on a non-high tech EMR now, in order for replacement, and only 5% of the funding can go to that total for the entire state. But you could advocate for upgrades. With our work for the interoperability with iHigh, the state, through our statewide funding, will be paying for that to some extent. Like, for example, we're looking at expanding, the FQHCs use a vendor that helps to do population health and population health management. So how, if the state came in and helped support that through iHigh, could that be extended to more FQHCs and other, including behavioral health facilities as well? So I
So,
don't want to,
Dr.
yeah.
Weaver, we also
Mhm.
submitted a proposal for community mental health for that same platform, for that
Okay,
expansion, for our data warehouse. So, you have that proposal from us,
perfect.
and it builds upon the work that IFCA and Azara have been doing.
Perfect.
What other questions? Anything? Okay, well, we're just over time. Dr. Weaver, any final words or thoughts for our members regarding these dollars?
Nope. Hang in there. We're all we're all in this together, trying to get through this first year. I do believe we're going to be successful. It's not going to be perfect. We are going to have to pivot and make changes in the future. So keep on providing feedback, and we'll continue to evaluate. But yeah, thank you guys for your time. I'll keep on updating you if you wouldn't mind as we move along. I think the reason why we keep on telling everybody all the initiatives, I also want to make sure that people are fully aware of everything that's coming out since it's a lot. So you can keep that in mind as you move forward. Like if you're thinking about we want to bring in students so maybe we can help recruit more providers, then you need to get your clinicians prepared to be preceptors, right? And be thinking about that. If you're like, we'd like to recruit a psychiatrist to our community, be thinking about that $300,000, be thinking about interoperability, be thinking about the healthcare academies and how you engage. Like I know there's a lot of focus on the regional grants right now, but there's a lot of things that are going to be going on statewide, so be keeping those in mind and preparing for those too.
Just to build off of that, I wanted everybody to be aware that we are going to have Dr. Yazel come to a Cup of Joe to talk about the mock initiative because he's been leading a lot of that. And I know there's been a lot of questions on that. I know Dr. Weaver hit that high level. And then we're also going to have Katrina Norris come to talk about the behavioral health workforce. So if there's another initiative within the rural health, they have point people that then can speak and get into the weeds as far as how you can apply it. And so that will be the next part of the Cup of Joes. This was just the high level to set the stage, and then we'll get into the weeds for everyone.
Awesome.
So, any other questions, thoughts? Thank you, Dr. Weaver, for your time. I
Thank you.
really appreciate it. And then, Trent, who is our Starbucks winner today?
All right. Thank you, Dr. Weaver. That was great information. Starbucks winner is Becky Glines today. Oh,
Nice.
I love, she
Awesome.
popped up. She's excited. That's great. Awesome.
Everyone loves Starbucks. And Becky, we'll see you tomorrow with our Justice Award. Looking forward to it. So if there's anything anybody needs in the meantime, please don't hesitate to reach out. Looking forward to seeing everyone either in DC or at our July meeting. And we will get the next upcoming Cups of Joes out as we get the speakers locked in. So really appreciate everyone. Have a great day. Take care.
Thank you.